I'd like to introduce Dr. Alexander Sandhu, who is the PI for this study called PHARM-HF A&F. So congratulations on your study today that you presented and presenting it at AHA. I'd like to learn a little bit more about the study. So what was the impetus for starting this study?
Yeah, thank you. We know that the heart failure has a huge prevalence in the US with over 6 million individuals suffering from the disease. We're really fortunate at this time to have incredible therapies that substantially reduce morbidity and mortality for this condition. But we know that use of these medications remains low across health systems throughout the US. So I think there's an incredible urgent impetus to find different strategies, probably multi-pronged strategies, to really improve heart failure care. And we think one strategy with a lot of real potential and scalability is expanding the heart failure care team, and especially expanding the team to include pharmacists for GDMT, heart failure guideline-directed medical therapy optimization. So that was the real impetus for how can we do that.
And it is a very unique aspect in terms of expanding to including pharmacists as providers for optimizing heart failure GDMT. Can you tell us a little bit more about the intervention that was used in the study and about the setting?
Yeah, thank you. The setting is in the Veterans Healthcare Administration, the VA. The VA is the nation's largest integrated healthcare system and has a rich history of pharmacists driving care, especially in hypertension and diabetes. Specifically, every primary care clinic practice in the VA has a pharmacist embedded in the clinic who helps manage hypertension, diabetes, and high cholesterol. There's been an increasing push to expand that scope to include chronic conditions where there's a lot of opportunity, like heart failure. In this study, what we sought to do was to understand if we can provide additional education as well as nudges to pharmacists in the form of kind of regular reports of how much heart failure care they're doing, can we really expand how much heart failure care is being provided by those pharmacists?
Okay, that's great. And your intervention was audit and feedback and education. Anything you want us to know more about that intervention?
Yeah, we randomized the pharmacists to 3 different arms. In one arm, they received audit and feedback reports, which were monthly reports of the frequency with which they adjusted heart failure medications for their patients in prior months and how that compared with their peers. They also received reports about their guideline-directed medical therapy rates at their facility compared to other facilities. In addition to that, they received education. That education consisted of webinars where we actually talked about challenging heart failure cases and talked about guideline-directed medical therapy, and a website we built with kind of an array of tools and resources to help pharmacists with heart failure management. That was the first arm. In the second arm, we had the exact same intervention, but we added patient-specific reports where they got a list of several patients in their primary care panel that had gaps in their medical therapy, with the hope that that would help them identify those patients, bring them into their clinic, and optimize therapy. In the third arm, we provided education alone. So it was the same educational resources and webinars without those monthly emails.
Okay, great. Thanks for clarifying all those details. So can you share with us some of the key findings that you found in the study?
Yes, we found that in all 3 arms, there was a significant increase in the frequency which pharmacists took care of heart failure patients, and an increase in the frequency with which they adjusted medications for patients in their panel. We found that there was a significant but small difference between pharmacists that received the audit and feedback reports in addition to education compared with pharmacists that received education alone. We found that there was no significant difference between the pharmacists that also got the patient reports and those that didn't get the patient reports. We also looked at guideline-directed medical therapy for patients that were cared for by these pharmacists and in their panels, and we found that there were high rates of medical therapy up-titration or initiation across all 3 arms, but for beta blockers, RAS inhibitors, and SGLT2 inhibitors, we didn't see any significant differences between the pharmacists that received audit and feedback with education compared with education alone. For MRA therapy, we did see a small significant difference with pharmacists that received the audit and feedback reports having a higher rate of initiation or up-titration compared to those that received education alone.
Okay, great. Very interesting findings and very, again, novel in terms of what was done. Did any of the results surprise you?
We were surprised by multiple factors. We were surprised that the patient-specific reports didn't have more of an effect. Pharmacists in the VA either will see patients because they're referred to them by primary care cardiology, or they can identify patients on suboptimal therapy and actually reach out to them to pull them into their clinic. So we thought that the report of patients that they could potentially identify and pull into their clinic would have more of an effect than it did. We were also a bit surprised by the amount of variation across the 8 different sites in our study. We found that there was no significant effect in 4 of the sites, and in the other 4 sites there was still quite a variation, with 2 sites that had much larger effect than the other 2.
I was very curious about the variation. So are you having any further steps to learn about the success of some of those sites that maybe were a little bit more successful in implementing the intervention strategies?
Yeah, we think that's critical. We think we really need to understand the context that existed for why some sites were able to be successful, so we can really replicate that and extend that to the other sites. So right now we're in the process of qualitative analyses, both interviewing the pharmacists, interviewing their supervisors, and then doing surveys of the pharmacists to try to understand what was it about the setting of some sites that enabled this intervention to be much more successful than in others.
Okay, great. And so what are some of the takeaways that you want people to think about in terms of potentially using this in their own practice or further steps?
I think there's a huge opportunity here with pharmacists and even beyond pharmacists, with nurses and others, to really expand the care team that provides chronic disease management in the U.S. I think this is one example of a strategy for how we can help train an additional workforce and give them experience and nudge them to providing that care. I hope that this serves an example for how we can test more interventions like this, how we can adapt this intervention to hopefully be more effective and scale and test it as we scale. So I'm really excited about the opportunity of really expanding the workforce that helps manage the kind of epidemic of chronic diseases that are coming.
Yes, this is very exciting and interesting findings, as you say, and I really look forward to seeing the next steps of your research team and what you do with this. I hope others take away also the potential of pharmacists in the primary care setting, which again is very unique, to try to optimize GDMT going forward. Thank you very much for sharing some of your findings with us, and congratulations again.
Thank you very much.
Thank you.